Hello, friends. Today we have hit half a century together. Thank you for listening to my lectures evening after evening and encouraging me to do better day after day. At the same time, thank you for giving your critical comments so that I can make minimum mistakes. Today, I selected this topic because it's a very important topic for all the postgraduates. It has come as a long question in one of the question papers. It's also sometimes a short note. And for practicing obstetrician and gynecologists, this is a very important issue. And now that more and more women are attaining menopause and living longer, and we need to know how to give postmenopausal therapy, when to give, when to start, when to stop, how much to give. All these are the doubts that people are having. So I intend to clarify some of these doubts today. So let's go ahead with the topic because there's lots to understand properly before we start treating. So I need some time to explain all these things. First of all, the name is menopausal hormone therapy, which was earlier called HRT, hormone replacement therapy. Why it is wrong to say it is hormone replacement therapy? It's wrong to say because though we are giving hormones here, it's not like that we are giving hormone replacement only in the menopausal age group. We also give in younger girls, especially if there is Turner syndrome. And there are many other situations where we may have to replace the hormones, especially if you did a gonadectomy for a testicular feminization syndrome. So all that is hormone replacement therapy only. So if you give that replacement during menopause, it is better called menopausal hormone therapy. So I would like to call it by that name only. It's not new. It is already been in existence for a long time now. Let's go through the stages or nomenclatures of normal reproductive aging first. So there are different stages. It starts from -5, -4, and -3. What do you call this? It's reproductive age group, which is again divided into early, that is -5, peak -4, and late -3. What's the duration of this reproductive age group? It's variable. Of course, depends upon when one attains menarche and one attains menopause. Menstrual cycles are highly variable and irregular in the early part, but then they become fairly regular in the peak reproductive age group. Endocrinology wise, initially there will be normal FSH, and towards the end of reproductive age group, the FSH starts rising as the number of eggs come down and the feedback goes down to the pituitary. -2 and -1, earlier it was called climacteric, now we call it menopausal transition, which is again divided into early and late, which can also call it perimenopausal age group. The duration again, of course, is variable. It can be few years to sometimes even up to 5 to 6 years. Menstrual cycles are variable again, more than 7 days in the early transition period, and in the late, they skip more than 2 cycles, and amenorrhea of more than 60 days can be seen. FSH is ever rising. Then comes this median age, that is final menstrual period, approximately 51 years. It's an average between 45 to 55. So we take it as around 51 years. Thereafter, you have +1 and +2. That is postmenopausal age group, which is again divided into early and late. Early further is, first one is 1 year A and next 4 years is B. What happens in that 1 year? There is amenorrhea of 12 months. And then finally in the late, no menstrual cycles at all. FSH initially rises, but towards the end, pituitary also gives up and there will be decreased FSH in the late menopausal period. This is a very important slide. You can take a screenshot of it if you like. The stages most likely to be characterized by vasomotor symptoms, that is the early postmenopausal symptoms. Now, why we should give menopausal hormone therapy? We all know that the spectrum and intensity of perimenopausal and menopausal symptoms are due to the effect of decreased circulating levels of estrogen on various organ systems. Though during the reproductive age group, estrogen and progesterone both are required, but after menopause, only the estrogen is missed. Its effect are missed. So that is why we need to replace estrogen. You may ask me, then why are you giving progesterone? Progesterone is given only to negate the unopposed estrogenic action on the uterus. So if a lady doesn't have uterus, then there is no need to give progesterone. So I hope it is very clear. It is because of the decreased effect of decreased circulating levels of estrogen on various organ systems. What is the definition of MHD? MHD is a broad term to describe both unopposed estrogen use for women who have undergone hysterectomy and combined estrogen progestin therapy for women with intact uterus. I hope you're not confused. Yes, we do give progesterone in the MHD, but only in women who have got uterus. If the woman does not have uterus, MHD will be only estrogen. What are the symptoms that we talk about? Irregular menstrual cycle is the most important symptom actually in the menopausal transition. Hot flashes or flushes, whatever you want to call, is the most common distressing symptom of menopause. 60% of the women definitely feel it. Then whole lot of symptoms are grouped under what is called genitourinary syndrome or GSM, which could be vaginal dryness, soreness, superficial dyspareunia, urinary frequency, and urgency. All are because of lack of estrogen. Psychological symptoms, mood changes, insomnia, depression, anxiety. Unfortunately, or whatever you say, it's a fate. This is the time in a woman's life when she's attaining menopause, there is a change in the hormonal milieu inside. And at home also, there are things changing. The children have become maybe adolescent or adults, and they will pose a lot of problem. In the office, in the workplace also, there is a lot of problem. Husband may be retired or retiring, and he may be at home and causing a whole lot of problems. So that's why there are mood changes, insomnia, depression, and anxiety. Menopausal effect. Why these problems occur? The main problems are due to vasomotor changes in the vasomotor system. There is hypothalamically mediated vascular instability. That is the reason why a lady will have hot flushes. In the urogenital system, there is atrophy and thinning of the mucosal lining of urethra, urinary bladder, vagina, and vulva. There's loss of vaginal elasticity and distensibility. That's why they would have some sort of dyspareunia. There is reduced vaginal secretions, and there's degeneration of subepithelial vasculature and the supporting subcutaneous connective tissue that is blamed for stress urinary incontinence. That's why there have been injections of fat underneath the vesicourethral angle, and things like that have been tried, and even estrogen patches or estrogen creams, local estrogens have been prescribed. Bone metabolism. Definitely estrogen is required to drive the calcium into the bone. Progressive bone loss occurs when there is menopause. And on cardiovascular system, there is increased susceptibility to heart disease. Until the age of menopause, women have the advantage over men, but that advantage is lost soon once they attain menopause, the advantage of estrogen. What is the goal? Primary goal is to relieve hot flashes. This is the most distressing, acute, immediate problem. Usually, they need systemic estrogen for this. But it can be managed with other modes also. Whereas secondary goal is to relieve other symptoms associated with perimenopause and menopause, such as sleep disturbances, mood lability, depression, joint aches. Again, these require systemic estrogen. But genitourinary problems should be managed with local estrogen. I have to talk about WHS study whenever I talk on menopause. Some 10 years ago or 10, 15 years ago, I was invited by Dr. Geeta Arjun to talk in progress. That's where I talked entirely on WHS study. But today I'm just going to talk 1 or 2 slides. This is the study, that is Women Health Initiative study. It shook the world. There were 3 arms. Number 1 was estrogen only arm. Other one was estrogen and progesterone arm. And then there was just calcium and other vitamin D arm. They had to stop the estrogen progesterone arm because there was a relative increase in the breast cancer. And that really shook the world. But it was a statistical jugglery. There was absolute risk of only 0.008. However, whenever you talk about cancer, women get scared, or anybody would get scared. Then they continued with only estrogen arm and calcium and vitamin D arm. They stopped estrogen arm also because there were more strokes, more cardiac problems. And then they continued only with the vitamin D and calcium arm. But interestingly, when they followed up all the ladies, even after stopping estrogen, even after stopping estrogen progesterone combination, the problems kept on increasing because there was a problem in their case selection. They selected women from perimenopause until the age of 80 or 85. As the age advances, naturally you will have more heart problems, you will have osteoporosis, you will have cancers. That was not taken into account. Anyway, I'm not here to argue with the study which is already been done and dusted, but definitely they pointed out major risk, that is breast cancer, as I said, CHD, stroke, thromboembolism. In fact, US Preventive Services Task Force also included these in their recommendation statement. Other risks told by WHS study: weight gain. Leiomyoma may become symptomatic, obviously. When you give estrogens as leiomyomas, which are otherwise shrinking after menopause, they can become symptomatic. Increase the risk of developing SLE. Increase in seizure frequency may be associated with onset of asthma and worsening the incontinence. Worsening the incontinence. I was just telling that estrogen can actually improve the incontinence, but they said it is worsening the incontinence. Obviously, they would have overlooked other problems in the particular section of ladies. Whatever it is, this was good enough or bad enough for women to shun menopausal hormone therapy. They got very scared, and as you could see here, the menopausal hormone therapy use declined. In 1999 to 2002, it was 22%. It came down to 12% when the progesterone arm was stopped in 2004-05. And further, it came down to 4.7% in 2009 to 2010. So it was for North American Menopausal Society come up in 2017 with the recommendations that MHT is indicated for the management of menopausal symptoms. Yes, you may not give it like vitamins and peppermint, but it is definitely required to relieve the symptoms. I remember very well in the early 90s, I myself used to go and give lectures everywhere saying that the menopausal hormone therapy, those days I used to call it HRT, should be started before attaining menopause and should be continued till the person dies. I will not talk like that anymore. It is totally changed. Now, as you can see here, it is recommended only for menopausal symptoms, but not for the prevention of cardiovascular disease, osteoporosis, and dementia, even though estrogen loss is going to give rise to these problems like osteoporosis, cardiovascular disease, and dementia. But we have seen cardiovascular diseases can increase if you give estrogen. It is a catch-22 situation. The deficiency causes problem, but giving that also causes problem. So that's why it should not be given for the prevention of those problems. Although MHT may help prevent and treat osteoporosis, it is seldom used solely for this indication alone. American Society for Reproductive Medicine said the use of estrogen plus progesterone decreases the risk of fracture in postmenopausal women, of course. But the net benefit does not outweigh the increased risk of stroke, invasive breast cancer, dementia, gallbladder problems, and deep vein thrombosis and pulmonary embolism. So it's a tough choice in the prevention of osteoporosis versus all these problems. So we have to make a very considered decision. Again, North American Society said the benefits of MHT appear to outweigh its risk for most symptomatic women who are either less than 60 years or less than 10 years from menopause. This slide has to be understood very clearly. Other day when I was giving talk somewhere else, there was a question and a lot of people were getting confused. I would like to clarify this very clearly. What it says is that you can give menopausal hormone therapy up to the age of 60, considering or outweighing the problems in a symptomatic woman, or within 10 years of menopause. What does it mean? Suppose a lady had attained menopause at the age of 45. The first clause is automatically cancelled. In this lady, you can give up to 55 only. I hope I'm clear. If a lady attains menopause 50 or after that, you can give MHT up to 60 years. But if a lady attains menopause before the age of 50, you can give up to 10 years only. If she attains menopause at 45, you should stop MHT at 55. 46, stop at 56. 47, stop at 57. And like that. Other benefits, reduction in frequency of recurrent urinary tract infections. It may improve balance and reduce the tendency to fall. That's very important because even though there is osteoporosis, unless you have a fracture, it won't really cause problems to you. So the fracture is because of a fall, and that is because of the imbalance. So it may really help in achieving that balance. It preserves the thickness and the collagen content of the skin. That's exactly why sometimes women take estrogen to have that glow on the skin. Risk of cataract formation appears to be decreased by long-term estrogen therapy, but you should not take long-term estrogen therapy for the purpose. It may reduce the risk of osteoarthritis, not osteoporosis, osteoarthritis as well. And there is variable effect on quality of life, and it alleviates dyspareunia as well. ACC and AHA, American Heart Association, they have recommended evaluating CVD risk in women contemplating MHT. 10-year CVD risk, years since menopause of onset, less than 10 years. The 10-year CVD risk is low, that is less than 5 years, if MHT is okay in that case. If it is moderate, 5 to 10 years, MHT is okay, but you choose transdermal patches and things like that. Whereas if the 10-year CVD risk is very high, more than 10%, and if your years of menopause of onset, it should be less than 10 years, which I told you. In this particular case, avoid MHT if the risk is more than 10%. ACOG and North American Menopausal Society both together now started giving recommendations, and I have indicated what is the grade of recommendation or level. Level A is the highest grade, good or consistent scientific evidence. Lowest effective dose for the shortest duration in symptomatic women. I'm going to repeat that. Lowest effective dose for the shortest duration in symptomatic women. Not only that, I want to later highlight it. Systemic MHT with just estrogen or estrogen plus progesterone is most effective approach for vasomotor symptoms. Local estrogen therapy best for isolated atrophic vaginal symptoms. But what's the guideline? Lowest effective dose for the shortest duration in symptomatic women. Level A again, alternatives to HT, hormone therapy, for relief of vasomotor symptoms can be selective serotonin uptake inhibitors, fluoxetine, selective serotonin and norepinephrine uptake inhibitors like duloxetine, clonidine, centrally acting, and gabapentin. These will calm down the nerves. That can also be given. Level B, that is limited or inconsistent scientific evidence. Data does not support the use of only progestins. I told you right in the beginning of my talk, only progestins are of no use. Testosterone, no. Compounded bioidentical hormones, no. Phytoestrogens. Many people think that phytoestrogens are the best alternatives for estrogen, but data does not support the use of it. Herbal supplements. Well, now naturopathy, natural things, herbal things, Ayurveda, and anything that sounds natural has become such a fad. People think that it is totally safe. It's not really true. Only lifestyle modifications. Lifestyle modifications will help, but not only lifestyle modifications. That will not help. Again, level B, common sense lifestyle solutions are definitely beneficial, but the evidence is not very good, but still fine. Cotton clothing, welcome. Lowering the room temperature, ACs. Consuming cool drinks, not hot drinks. Avoiding alcohol, caffeine, smoking, hot and spicy food or drinks, and stress. This definitely helps. Non-estrogen water-based or silicone-based lubricants and moisturizers, they are good. Level C, that is based primarily on consensus or expert opinion. Of course, there is nothing to harp on this. Individualize the decision to continue hormone therapy. What are the drugs used? This is the most important part of the talk. Estrogen. That was there right in the first slide. You have to replace estrogen. It can be alone, continuous in hysterectomized women, no harm, or with progesterone in women with uterus. Again, when you give this, there is no need to stop. It can be given continuously, because if you stop, they will again start menstruating in between, and that is distressing to them. Progestins, cyclical or periodical, always along with estrogen. Tibolone 2.5, when it came like one big panacea, but later it's faded away. It is less effective than estrogen. Higher risk of breast cancer and stroke, latter, of course, after 60 years. Then came raloxifene for osteoporosis. Higher risk of DVT and hot flashes. That's the disadvantage of raloxifene. It's good for osteoporosis, but hot flashes can be really, really bad with this. Which estrogen is the next question? For a long, long time, we had equinal estrogen, which was produced from the urine of the horses. But now it is not. All types of estrogens are effective in relieving hot flashes. However, 17-beta estradiol, that is 17-BE, is better than conjugated equinal estrogen. Estradiol valerate, it is having a similar structure to 17-BE and is rapidly metabolized to 17-BE and valeric acid. Has shorter half-life and fewer side effects than ethinyl estradiol. This I want to clarify. Many people think, many practitioners, especially general practitioners, they give OC pills as menopausal hormone therapy. It's not correct to give that because the OC pills have got ethinyl estradiol, which is synthetic and highly potent and very, very detrimental as far as the thromboembolic phenomenon is concerned, especially when you give in an elderly lady for a long time. So estradiol valerate is better than that. 1 milligram estradiol valerate is equal to 0.76 milligrams of estradiol, as you can see. There are many formulations, oral. I don't intend to talk about each one of them. You can see this. If you want, you can take a screenshot. More oral estrogen and plus norprogestin combinations. And then you have got estradiol patches, whole lot of them, twice a week, or maybe once a week or weekly. Then you have got estrogen progestin patches, combo patches, and you have got topical gels, topical spray, vaginal rings, and depot options, oil, intramuscular, everything is available. Of course, you can't get rid of all these kind of things. Vaginal rings, vaginal tablets, vaginal cream. But let's see how oral versus transdermal pitch against each other. Oral should be avoided in women with hypertriglyceridemia, active liver or gallbladder disease, or known thrombophilias and venous thromboembolism. But it may be, transdermals may be preferred in these women, especially with women with migraine, headaches, and auras. Oral, more favorable effects on lipid profiles, that is increasing HDL and decreasing LDL, but transdermal will not have any favorable effect on that. Oral are associated with increases in serum triglycerides, transdermal not associated at all. Orals increase SHBG and decrease testosterone, lesser such effects with transdermal. Again, with oral, you have increased TBG and decreased thyroxine, but lesser effects with transdermal. So you can clearly see that there's a big difference between giving it orally and transdermally. Routine use of estrogen. The potency and therefore the doses of these estrogen preparations differ, but differ little in their ability to elevate hot flashes. Ultimately, the choice of preparation or dose is based upon patient preference. If she wants patches, give it. If she wants ring, give it. If you want gel, give it. But if she doesn't mind taking orally, give it. Drug availability. Everything will not be available everywhere. And of course, the cost. What is the dose? 17-beta estradiol standard dose is oral therapy start with 1 milligram per day, transdermal 0.05 milligrams per day. These are adequate for symptom relief in the majority. In younger women, after bilateral oophorectomy, you may actually give a little more, 2 milligrams, and transdermal 0.1 milligram per day. For the first 2-3 years after surgery, then could be tapered. The current approach is to start with lower doses such as transdermal 0.025, not even 0.05, and oral 0.5 instead of 1, and titrate up to relieve symptoms. Lower doses are associated with less vaginal bleeding, breast tenderness, fewer effects on coagulation and inflammatory markers, and possible lower risk of stroke and VTE than standard dose therapy. Which progesterone? Micronized progesterone 100 to 200 milligrams per day is preferred as they are safer for CVS and possibly the breast. It is medroxyprogesterone acetate that was used in WHS study and that got a bad name. And the dosage was the same, 2.5 milligrams per day. While MPA is endometrial protective, it was associated with excess risk of coronary heart disease and breast cancer. Just now I told you about that. So women who have undergone hysterectomy should not receive progestin, as there are no other health benefits other than prevention of endometrial hyperplasia. In fact, there is a risk of coronary heart disease and breast cancer. Other drugs, calcium, vitamin D, vitamin K, diet rich in fruits, vegetables, low-fat diet, water, probiotics, antioxidants, give in plenty. No problem. Alternatives, clonidine, as I already told you, 0.1 milligrams weekly transdermal patch, SSRI paroxetine, 1 to 20 milligrams, SSRI venlafaxine, and gabapentin, 300 to 900 milligrams per day can be given for hot flashes. Drugs with unproven efficacy greater than placebo used for treatment of vasomotor symptoms are isoflavine supplements, soy products, black cohosh, and vitamin E. But they can be given, but they are abused. But these drugs definitely avoid alcohol, high salt diet, excess phosphorus in carbonated soft drinks, hydrogenated oils. No. Reduce sugar and coffee. Monitoring, transvaginal sonography, endometrial sampling, mammography, LFT, lipid profile, venous Doppler at regular intervals. What is the regular interval? Mammography, they say 1 year. LFT, maybe 6 months, or depending upon how the values are increasing. Endometrial sampling also can be done once a year, but before that you can do TVS. Venous Doppler if the patient complains of any symptoms. What are the side effects? Breast soreness, mainly because of estrogen. Mood symptoms and bloating, mainly because of progesterone. Vaginal bleeding, when you give estrogen, progesterone, and then withdraw. Alternatives for progesterone also have been thought of, LNG-IUS, especially if the patient had problems with endometrial hyperplasia. Conjugated estrogen or bezodoxifene, that is SERM, can also be considered. What are the contraindications? There are no absolute contraindications for MST as such, but relative contraindications are history of breast or endometrial cancer, but some consider them as absolute contraindication. Severe active liver and gallbladder disease, again, some consider it as absolute contraindication. Hypertriglyceridemia, thromboembolic disorders, undiagnosed vaginal bleeding, and endometriosis and fibroids are relative contraindications. Now I end with 2 slides. Decision making. Menopausal symptoms are not there, what to do? And look for any risk for osteoporosis. No risk for osteoporosis. Then there is no need for MHT at all. But if the menopausal symptoms are not there, but there is a risk factor for osteoporosis, then refer for bone density scanning. If the bone density scanning shows normal bone density, advise about diet and lifestyle only, no MHT. But if there is low bone density, look for risk factor for CHD. If it is not there, you may consider ET, EPT because there is low bone density. But if there is a risk factor, advise only lifestyle changes and alternatives. On the other side, if menopausal symptoms are present, discuss MHT with the patient. If she doesn't wish to have MHT, advise about alternatives. But if she wishes to have that, ask family history of breast cancer. MHT on short-term basis can still be given. Recent history of breast cancer, discuss alternatives. Risk for CHD, management of hypertension plus hyperlipidemia plus alternatives only, no MHT. So final sentence, can anybody guess? Lowest effective dose for the shortest duration in symptomatic women only. Thank you very much.